Some further controversy to continue that exact same topic is, when do you have to do something and what all do you have to do? This is a 54-year-old woman who presents with this incidental finding on imaging. You can see here it's bright on T2, classic sort of bubbly appearance. There is a small amount perhaps of intradural extension. There is erosion of the clivus, and it is completely non-enhancing. So what is ecchordosis? I think if you ask 3 people, you'll get 3 different diagnoses. Certainly if you ask radiologists, they will say it shouldn't have any bony erosion. It has this typical bony stalk. It may have it's an intradural tumor. These are thought to be congenital benign hamartomatous lesions. I'm not sure I agree completely with that, but they are a benign notochordal tumor. They obviously have to be asymptomatic, but you shouldn't see invasion of bone theoretically. And histologically, there's a question, can they have proliferation or not? And if you ask a pathologist, they say it's not proliferation per se, but it's rather if there is evidence of invasion of the surrounding tissue. Sometimes they even take into account radiology. So these are very fuzzy definitions of a disease. Interestingly enough, I found old imaging where this had not been called, and this was clearly 10 years previously, smaller. So it is not quite doubled, but almost doubled in size over 10 years, which I think maybe makes this a little more challenging. So I would ask the group, what would they do? I believe this is one of our polls here. So the options are just to continue to observe this. Its growth rate is obviously extraordinarily low. Would you do a transcatrosal or some sort of transcranial approach, maybe even a far lateral or retrosigmoid? Or would you do an endoscopic endonasal resection or just radiate empirically?
I think let's see the answers. Here we are. 55% observe.
Yeah, I think those are both very reasonable options. And this is what I discussed with the patient. Offered further observation, but told her I could not be sure where this falls, but I felt it was clearly on the benign end of the spectrum. She strongly wished to have resection, especially given the growth of the lesion. And here's the post-op. You can see a very radical resection. I did not try to just pour this out, but this, to me, is a complete resection. And the histology was called a, quote, low-grade notochordal tumor because, they won't make the diagnosis of ecchordosis without some of these radiographic. And so even when I pushed my pathologist, this was what they gave me, was low-grade. And these are clear margins. And if you look at the pathology, it has absolutely no deletions and it did have a Ki-67 of about 1%. But to me, this patient does not need any other treatment. And this probably is consistent with what we would call ecchordosis, but I'm still not sure what ecchordosis is. I think there's a spectrum of chordoma disease, and I think this falls on the most benign end of that spectrum. Another tumor, this is now an 11-year-old girl, so a much different scenario, and she's presenting with symptoms. So not asymptomatic, but a similar kind of tumor, largely intradural or interdural. And again, we resected this, and here's the post-op. Again, gross total resection, including pituitary transposition, resection of the posterior clinoids, etc. Here is, interestingly enough, if you look at part 2 here, the left posterior clinoid had chordoma in it. The right posterior clinoid did not, so this is very important. But this is what I would call, quote, negative margins. So if you look at all of our lateral dural margins and bony margins, they show that they are clear of tumor. Here is the fish, which is what we started looking at for several years now. And you can see here on P16 fish, there were no homozygous deletions and a relatively low rate of loss of 1P on fish. So this is a paper that was published. You can see the reference there in 2019. We looked at about 100 patients and looking at 3 different groups for prognosis based on their fish for these 2 different deletions, which turned out of a multivariate analysis of all things, including Ki-67, to be the most meaningful. And this actually breaks patients into 3 very distinct groups based on prognosis. That best risk group, which has a little or no mutational burden, has almost no progression after either resection or radiation. And then the highest risk group progresses no matter what we do. So I think that this is a very significant thing to look at and way to understand these patients. And so for this particular patient where they had no homozygous deletions in P16 and had less than 15%, which was our cutoff for 1P, we found that this patient did not need radiation because she fell into this phase. And especially for a young girl like this, I think this is extremely meaningful to understand the indolence of her particular tumor. Similar size tumor, slightly different location, craniocervical junction, 38-year-old man, presents only with headache, but still symptomatic. Also underwent the gross total resection, very happy with my resection, including margins. Also had negative margins in this particular case, including all of the soft tissue I could possibly think to send. His pathology, however, is very different. If you look at his P16, he has almost 84% homozygous deletion and a fair number of the cells with loss of 1P. So he falls in this intermediate prognostic group, and we found with further analysis that actually this is the group that perhaps which radiation makes the most difference, but especially with incomplete resection. With complete resection, even these may get less benefit. So I think this was a patient where we did offer radiation, but I think that still even needs to be studied further. And then finally, another somewhat controversial case, perhaps. We talked about this, and this is, of course, purely anecdote, but this is a 27-year-old man. He presented to me after having a craniotomy in an outside hospital. You can see here he had a left-sided temporal craniotomy, and he had a reasonable resection of the lateral portion of the tumor, but this was complicated by a 6-nerve palsy, and he has this residual and still some residual ataxia. So here's this tumor, grade 2 chondrosarcoma. You can see the compression of the brainstem, heavily calcified tumor, as you can see on this CT scan. And we did an endoscopic endonasal resection of the midline portion, decompressed his brainstem, but now have left him with this lateral petrous and cavernous portion of the tumor. So here's another poll question. What are the next steps for this patient? Chondrosarcoma, of course, transpetrous approach here could get you a greater resection. I would venture to say in a patient who's otherwise intact, except for a 6-nerve palsy, you cannot get a gross total resection in this case without significant risk and probably even carotid bypass. Would you radiate this patient, either proton beam or IMRT, or simply observe? So again, you saw a sizable residual, probably a quarter of the total initial tumor that's left. And this was a very large tumor, 27-year-old man, young man, very calcified chondrosarcoma, grade 2. Sean, what would you do in this case?
I would offer surgery to clear out the petrous apex disease. I agree with you. The disease within the posterior cavernous sinus may be difficult to get at the risk of sort of permanent morbidity. But at least to clear out the bony disease with the remnant petrous apex, I think would certainly change the radiation fields also. Eventually, if you are going to give radiation.
I'm probably the one person who said observe here, but I would wait for this moment and see what happens, see if it's growing or not, and not even offer radiation.
Okay. So the poll results are up.
So we had a lot of discussion with this particular patient, young man, very functional at this point. And this is his scan 10 years later with no further treatment, purely observation after now 10 years. So I think this is obviously the story is still out on chondrosarcoma, but some of these clearly are very indolent. If you look at their overall progression-free survival, this is the curve. Interestingly enough, one of my former fellows developed a simple grading system by looking at multiple different factors in a multivariate analysis and found that age and arterial encasement were the 2 key factors. And if you have a patient that you see here in the strata, which is in red, which is a patient who is young, who has no major arterial encasement or 0 or less than 2 arteries encased, they essentially don't have progression. And this was looking at, I think, almost 40 or 50 different patients. Whereas a higher grade patient with complete encasement and a greater age would progress regardless. So I think that there's some ability perhaps in these patients to try to understand, especially a young patient like this, where we get a reasonable, at least decompression observation over time to avoid morbidity may be an option. There clearly must be a molecular correlate to this that we do not understand. This may be a tumor like many others that has an IDH mutation subtype that we need to understand. And this is something that we're trying to look into and understand better.
So I'll just ask one question before we move on to Carl's talk. So given that we don't, any of us really understand ecchordosis fully, and I'm glad to hear you say that because that's okay for me to say that I don't understand it either now. And what do you think about a surgery first strategy, given we also don't understand the biology, given that we know that the surgery is safe and effective largely for these predominantly midline, smallish lesions? And that would then both protect the patient potentially from long-term unknown consequences and also give us more material to study to determine this biological basis better.
That's a tough one. I don't think we know the answer to that. I think that there are technologies such as radiomics, for example, or frankly, a very, very good radiologist who can give us enough confidence to pass that along to the patient. I do, to some degree, put this decision on the patient. I try to comfort them as much as possible. And if I think it's ecchordosis, I will be, I will tell them that this is unlikely to cause them problems in the near future. The thing that we don't know is nobody knows, is ecchordosis like a polyp? So can ecchordosis have a rate of malignant transformation? And nobody knows that. And I think that's the real question here. And the reason that I would consider surgery is not because I think it's malignant at this time, but is this a precursor that has the potential to become malignant? No chordoma can progress and change its mutational burden over time.